following lecture is aimed for dental students, interns, junior trainees, junior residents of oral surgery and oral maxillofacial surgery, as well as junior residents of other dental specialties. I also dedicate this lecture to my fellow colleagues and dental practitioners of several dental specialties all over the world. May you all benefit from it. In memory of my late parents, may Almighty merciful God rest their souls in heaven and peace. Please allow me to give a brief bio about the speaker. My name is Mohammed Al-Shulkami. I'm a professor of oral and maxillofacial surgery at the Faculty of Dentistry, Suez Canal University in Ismailia, Egypt. This lovely city, which lies around 120 kilometers to the eastern of the capital Cairo in Egypt. It was named after the late great ruler of Egypt, Khedive Ismail, the one who did the opening ceremonies of the Suez Canal in 1869. I'm also the professor and the supervisor of the Oral and Maxillofacial Surgery Department at Faculty of Dentistry, Sinai University, Kantara campus in Ismailia. I also worked as a part-time associate professor at MIU University and MSA University for several years. I'm a visiting professor at the Faculty of Dentistry, Beirut Arab University, in the Oral and Maxillofacial Surgery Department in Beirut, Lebanon. I'm also the managing director of the Egyptian Dental Center, a multi-speciality discipline dental and maxillofacial center based in Cairo, Egypt. The main topic for today, I find it one of the most important topics in the dental practice, is the management of the medically compromised patients. And we are discussing in this lecture one of the most important topics of the medically compromised patients, which is the renal disorders in the dental practice. What do we have here? We have chronic renal insufficiency patient, the patients on renal dialysis, and the renal transplant patient. The renal dialysis patient, we are going to discuss the pathophysiology, predisposing factors, signs and symptoms, treatment, potential risks, and last but not the least, we are going to talk about the management. The kidney is responsible for excretion of the waste products, and it determines how much water to be excreted in urine and the concentration of electrolytes as well. For example, if the patient is dehydrated from lack of water intake or exercise or illness, the kidneys is going to hold much water as possible and the urine becomes very concentrated, and vice versa, of course. This system is controlled by a hormone called renin, which is part of the fluid and blood pressure regulation system in the body. And this finds an interaction between the blood pressure rise and hypertension and the renal disorders. Actually, you cannot tell which is which started and led to the other one. Also, the kidneys are the source of erythropoietin, which is a hormone responsible to stimulate the bone marrow to make red blood cells. Actually, chronic renal disease is mostly preceded by pre-existing hypertension or uncontrolled and untreated diabetes mellitus. So what are the lab investigations that could tell you about the kidney function? Or we say they are the renal function or the kidney function tests. We have blood urea nitrogen, creatinine, and glomerular filtration rate. The blood urea nitrogen is measured in milligrams per deciliter in the United States and in millimoles per liter internationally, and around 7 to 20 milligram per deciliter or 2.5 to 7.1 millimole per liter is considered a normal range. The normal levels of creatinine in the blood differs from male to female. It's 0.6 to 1.2 milligrams per deciliter in an adult male and 0.5 to 1.1 milligrams per deciliter in adult females. The GFR or glomerular filtration rate, when you have a range of 60 or higher, this is a normal range. A GFR below 60, it's considered we have a kidney disease, like in the yellow color in the figure, and a GFR 15 or lower may denote kidney failure. What are the signs and symptoms of renal failure? The patient is lethargic, you have shortness of breath, generalized weakness due to anemia, generalized swelling and edema, loss of appetite. You might have congestive heart failure, metabolic acidosis, and high blood potassium, hyperkalemia. And this hyperkalemia leads to fatal cardiac disturbances or arrhythmias like ventricular fibrillation, for instance. We also have encephalopathy and pericarditis and hypocalcemia. And the patient is put on a dialysis machine 2 to 3 times per week to filtrate the blood from the waste products. And to facilitate connection of the patient to the dialysis machine, a vascular access shunt is performed, that is to say, connecting an artery to a vein in the patient and lead this as an ready access to the patient to give heparin prior to dialysis session in order not to have the blood clotted in the dialysis machine. So heparin is given before the dialysis session to facilitate the flow of the blood in the dialysis machine using the vascular access shunt. What are the potential problems and risks associated with the renal failure? Almost we have systemic hypertension or pre-existing uncontrolled diabetes mellitus. They are the backbones behind the renal failure. We also have metabolic radiolucencies due to secondary hyperparathyroidism, and this should not be mistaken for dental disease or radiolucencies in the panoramic view or in the mandible, should not be treated as pathology. The patient will suffer from anemia, as we said before, and uremia also leads to decreased platelet aggregation. It might lead to prolonged bleeding. We have impairment of the immune system and susceptibility to infections, so we have to guard this by prophylactic antibiotics. The patient on dialysis, regular dialysis sessions might contract hepatitis virus infections from other infected patients, unfortunately, so we have to screen for hepatitis B or hepatitis C and take the precautions as well. And let's see the outline of the management protocol. Regarding the appointment time in relation to the dialysis, it should be the day after the dialysis session to avoid the adverse effects of the heparin injected prior to the dialysis on the post-operative bleeding. We should consider giving the patient prophylactic antibiotics, and we should consult the physician regarding that. We should be instructed about the dosage and the type of the antibiotic and the period of prescribing such antibiotic. Always keep the consult of the physician or the connection with the physician former in a written form or in email fashion. Regarding IV fluids, we also consult the physician if the patient needs IV fluids or not. The vascular access shunt should be protected, whether from post-operative infection or bacteremia, and it should not be used under any circumstances for IV injection unless there is a life-threatening emergency. Of course, drugs to be avoided, on top of which are the NSAIDs and also cephalosporin, penicillin, and sulfa. And regarding the antibiotics and analgesics we usually prescribe to our patients. In such instance, we are dental practitioners, we are oral surgeons. We should relieve pain by our operatory interventions rather than using NSAIDs or antibiotics. What about having the patient scheduled for a hemodialysis session post-operatively? This can be done 2 to 3 days post-operatively, or otherwise, if the patient is going the next day, we should arrange to have good hemostatic measures and put well-packed sutures. During the visit, we should also monitor the blood pressure and heart rate. And of course, if proven that the patient had contracted hepatitis B or C viral infections, we should take the usual precautions. Now let's talk about the renal transplant patient. We are going to discuss the pathophysiology and the potential problems like the lowered immunity and gingival hyperplasia and cautions with the nephrotoxic drugs. The pathophysiology, of course, such patients were renal chronic dialysis patients, and they were lucky to find a matching donor, and they had their kidney and new kidney transplanted, so they are under immunosuppressive drugs to allow the new kidney to be accepted in the body and not to be attacked by antibodies and the immunity of the patient. So they have lowered immunity, and we have to guard against this by prophylactic antibiotics. So we need prophylactic antibiotics, and as we said before, we should consult the physician about the type of the antibiotic and the dosage of the antibiotic and the duration of the antibiotic. And regarding the induced gingival hyperplasia, it is caused by a drug called cyclosporin A, which is on top of the immunosuppressive drugs used. And some patients also are given corticosteroid therapy. And if the patient is on continuous corticosteroid therapy, we should guard against the adrenal insufficiency. And this should be discussed in the lecture of the endocrine disorders under the heading of adrenal insufficiency. We should, of course, avoid the nephrotoxic drugs, and on top of which is the non-SAIDs. And although they are very good painkillers and anti-inflammatories, but remember that we are dental practitioners and we are oral surgeons. We should operate to relieve the patient's pain. We should not put the patient on antibiotics and analgesics and sedatives to relieve pain. We should operate just by surgical exodontia or by endodontic treatment and pulp extirpation to relieve the pain. Don't rely on NSAIDs or steroidal drugs to relieve the patient's pain. And the gingival hyperplasia is one of the annoying problems that you face with renal transplant patient or other organ transplantation patients undertaking cyclosporin A. The mechanism of cyclosporin-induced gingival hyperplasia is yet unknown, although several postulations have been made, such as upregulation and expression of some salivary inflammatory cytokines, including interleukin 6 and interleukin 8, and the increased proliferation of gingival fibroblasts and keratinocytes. This gingival hyperplasia can be treated surgically, medically, or periodontally. I find that the good oral hygiene and encouraging the patient to do good oral hygiene measures, besides surgical excision, whether using the scalpel or the electroscalpel or electrosurgery or laser devices, I find this very beneficial. I've done a study on comparing the scalpel and the electrosurgical removal before, about 15 years ago. But let me tell you something, that this might need combination of treatment. Some authors have tried azithromycin as a medical remedy for such a problem, but I think it's a combination of several factors that we should combine surgical treatment with periodontal and good oral hygiene measures. And I believe that we would be in contact with our fellow colleague physicians and nephrologists to tell them, please, if you are planning for a kidney transplant for the patient, please send them to the dentist to have his teeth and his gum health evaluated before doing so and before putting him on the cyclosporin, because the cyclosporin, it should be taken for life. It cannot be dose modified, or it cannot be stopped. Maybe they can only dose modifying it or doing some modification in the dose or reduction in the dose, but they cannot stop it. A non-surgical approach has been tried in a case report in the Department of Periodontology, School of Dentistry, Hassan II University in Casablanca, Morocco. Periodontal management of cyclosporin A-induced gingival overgrowth. It was done by periodontal treatment, scaling, and root planning, and encouraging oral hygiene measures for the patient. The case was followed 2 months post-operatively and was followed furthermore for 2 years, and there was no recurrence of the gingival hyperplasia. And as we said, sticking to a good oral hygiene is mandatory in such cases, but should the gingival overgrowth happens again, we should try to remove it or deal with it surgically or medically. And as I said, we should inform our fellow colleagues in the nephrology section, or the physicians dealing with the case of the renal transplant or organ transplantation. Please, when you are planning such a case, send your patient to the dentist or the periodontist to outline any teeth or any problematic teeth that should be treated before going to such a surgery. It was once said, keep your friends close, but your enemies closer. Finally, I would like to thank you for your kind attention. Thank you so much.